For a while there, Sanjit Jolly and I were really getting acquainted with each other. It seemed like every time another study came out showing that thrombectomy didn't work, he, who was the PI of the total trial, would keep saying, just wait for the total trial results, because indeed they even expanded the trial, about doubled it in size so that they would get some really good data. And when the total trial results came around, it was kind of 3 strikes and you're out. Well, we now have more data. And so my guest today is wondering, despite the data, will we ever stop aspirating coronary thrombi? And I'm fascinated to hear the answer to that one. It's an editorial commentary in the January 25th issue of JACC Interventions, and I'm with Dr. James Blankenship, MD, who is Director of Cardiology for the Geisinger Medical Center in Danville, Pennsylvania. What gives? We have all this data now, and yet nothing seems to be changing.
Well, the data shows that routine aspiration of thrombi doesn't work. So the implication there is that there's no point doing it for every single STEMI case, but that doesn't mean that it's not effective in some selective cases. And while there is some data that in cases where you can see an angiographically large thrombus, that there is some benefit, at least not in the total outcome measures, but in the surrogate measures of outcomes. So there's some evidence that it works in patients with angiographically large thrombus. Those studies were too small to actually show a decrease in mortality.
You're actually commenting on a paper in JACO Dimensions, and it's for people presenting late after symptom onset with STEMI. Didn't seem to work, correct?
The theory was that for patients presenting late, 12 to 48 hours after a heart attack, that at that point the thrombi may be more organized, and if you don't aspirate them, it might be more likely to embolize downstream as a discrete embolus that then will occlude the vessel downstream, prevent collateral flow, and be very difficult to treat. The idea was that if it's more organized, maybe you can suck it out and get a better outcome and prevent downstream embolization when you do a PCI at that point.
But it just didn't seem to work.
Didn't pan out, nope.
Ironically, or interestingly, in the very same issue, there's a paper from Britain, and they're leaving it to the choice of the doctor, just like you said. They're saying on the basis of physician judgment, they had pretty much an all-comers trial, about 100,000 patients between 2008 and 2010. Thrombectomy plateaued slightly below 50% of all primary PCI cases, and in this trial, it failed too. So now, where are we?
Well, we're at the point where it's hard to show any benefit to aspiration thrombectomy based on trials. And what we do have is this marker of possibly increased stroke associated with thrombus aspiration that was shown in total. And so there is some concern. There was a large meta-analysis that showed a trend towards increase in stroke too. So there is concern that at least when it's done routinely, that there may be some increased risk of stroke. Now, that may be technique dependent also. So I think that when thrombus aspiration is done, it's incumbent on the people to do it, to try to do whatever they can to prevent stroke. And that may mean deeply intubating the catheter into the artery so that the material that's sucked back doesn't end up free in the circulation and possibly going to the brain.
In your editorial, you refer to it as the oculothrombotic reflex.
Right. So that goes back to the question of when, if ever, should we aspirate thrombi? And my point is that every person who does this has the experience of occasionally aspirating a large angiographically visible thrombus and sucking out a big red thrombus, sometimes a centimeter long. And
very impressive looking.
Very impressive. And then the angiographer will think, well, gee, what would happen if that embolized downstream and how could I ever get it out? So when you've done that a few times, you think, maybe there are some cases where it really is beneficial.
So what do you conclude from all this? Because the guidelines now seem to have come down on the side of, no, not really. I mean, they're saying they've downgraded routine coronary thrombus aspiration in STEMI from a 2A recommendation to a class 3. Don't do it.
Well, but they also recognize that selective aspiration may be appropriate, giving it a class 2B for selective thrombus aspiration. My point is that whatever the guidelines, human behavior being what it is, the effect of hauling out some of these huge night crawlers and then putting them back on your back table and seeing what you got out, that effect is going to be enough so that most people will, at least in selected patients, still want to accumulate the thrombus and aspirate it right out of there. So I think that no matter what else happens, that the experience of the individual person is going to compel them, at least in some selected cases, to continue to do it.
We have 2 studies now, just brand new in JACC Interventions. Is there any other study that can or should be done?
The other one that could be done would be, again, in angiographically visibly large thrombi to where the angiographer thinks that it should be aspirated, then to randomize and between aspiration and no aspiration. But that would take persons who who are willing to admit that there is clinical equipoise and are willing to say, even though I would love to aspirate that because it looks so big and so scary, that half the time I won't. So that's a study, and that would be the last study that could be done in hopes of finding some benefit to thrombus aspiration.
It's been a wonderful series of studies, and it's certainly filled my conversation with some very interesting people. So we still could end up talking about this in the future, is what you're saying.
We could end up talking about it, but that would be a much harder study to do than soldier trial.
Heavens, yeah. And I'm not sure if you could get anybody to do it, but it will be interesting to see. These papers that we're talking about, there's actually 2 papers and their accompanying editorial commentaries. You really should go read them. They're in the January 25th issue of JACC Cardiovascular Interventions. Please see those online at Cardiosource World News, where I'm Executive Editor Rick McGuire.